So when we discuss the high-risk follicular lymphoma patients, I think we have a different situation. If anybody is really high risk, I mean, we should remember that the outcome of this patient with follicular lymphoma is really has been markedly improved over the last 2 decades. I mean, most patients will be alive 10 years after diagnosis, between 80 to 90% of the patient, but many of them will have received treatment. And the question is, how do we define the patient who had higher risk and may succumb from the disease during the first year of therapies or management or later on? So I think the way I have framed that was, let's discuss a little bit the first line setting, if anybody is really high risk in the first line setting, and then the relapse refractory setting. So maybe Stefano, just to add directly a first question. Do you think when you encounter a patient that come to your clinic with follicular lymphoma, that you can identify some features in these patients that will define a patient of being high risk at diagnosis?
But I think that this is an important topic to discuss, and I think we have a lot of data accumulating mostly in recent years, and with the that can contribute really to provide a good outlines of what is currently known for educational purposes.
So I think the first question I wanted to ask you, well, the connection was a little bit up and down, was when you see a patient coming to your clinic with newly diagnosed follicular lymphoma, what are the criteria you look for to identify this patient of being high risk? What are the considerations, whether they are purely clinical, whether they are based on the pathology report? Are you relying on molecular tests? Are you relying on imaging to identify some patients that you might consider of high risk, if any?
Yes, sure. So it's a sum of different factors, even if none of these factors keep considered individually can be considered as a predictive factor. So we have a lot of prognostic features like FLIPI, the clinical index, but we all think we all look at the PET results, for example, to look at the SUV, the histology to look at grading. Something is changing with the new classification. So it's mostly based on experience that is also limited and guided by the option that we have available for the treatment of the patient. So the question is basically whether we need to treat the patient or not. And in this context, I think we do look at the risk features, but mostly at staging, considering the risk. And for the systemic therapy for high tumor burden, I think there is a sum of features that are mostly considered based on the experience of any of us. So it's a sum of factors that cannot be classified into an algorithm. There is no black and white rule for the decision.
Any further insight regarding this gray zone? You mentioned the imaging results, the high SUV. You may eventually mention some biological parameters such as patient with high LDH, or you mentioned the grading. What's your opinion? Do you think we can approach patients in need of therapy because they have symptoms or significant tumor volume but are grade 1, 2, normal LDH, PET-CT with SUV in 8, 6, 6, 8, or patient with very bulky mass, LDH 1.5 normal value, SUV at PET at maybe 25. What do you think we should approach this patient similarly, differently? I don't think we have data. I agree with you. However, in our practice, I think we pay a little bit more attention to some of those.
As basically, so considering and comparing the two most frequently used option, that is R-Benda and R-CHOP, we know from the gallium data, also from our data, that there is no rule again to describe which is the patient for CHOP or Benda. and we don't have validated tools. So this is, I think, a field of investigation that should be carefully look at these features. Basically, the young patient is more frequently treated with CHOP, and we use CHOP very frequently in follicular lymphoma in young patient, and mostly follicular 3A also is a feature that is more frequently, but not absolutely considered to address the patient to CHOP and to instead of bendamustine, and all the other patients are treated with bendamustine. But it's very difficult to define a rule. So very good field for discussion and for education also.
I think Martin Drayling wants to mention his expert opinion in this field.
Well, of course, I can only echo what the others said, but I have some strong feelings, not more, because as you mentioned, there are little evidence. But if there's a case, let's say, with doubled LDH, independently whether the transformation has been confirmed by histology, there could be still a sampling error. And in these patients, I strongly would advocate CHOP.
I think Greg also like to provide his opinion.
Yeah, I agree with others that this is a very challenging area, and to identify the patients at the high risk. The bottom line is we don't really have a good way of stratifying patients at diagnosis, which would be based on molecular classification in follicular lymphoma. There is a M7 FLIPI, but even this one actually requires flipping those clinical parameters taken into account and has actually a limited utility. So this is an area of future unmet need. Can we actually use some of the molecular markers at diagnosis to predict outcome of patients with different induction therapies, and also the risk of relapse, particularly relapse within the first 12 to 24 months? What Martin has mentioned, that observing the increased LDH is certainly concerning for transformation in some patients. Stefano also mentioned that high SUV on the PET scan could be concerning for it, but typically would like to try to prove it by biopsy if we can. Sometimes it's not feasible, and would assume that those patients could be at the high risk of transformation. However, again, those are all imperfect and based on more of a clinical impression. I think what could be really helpful here over time, and I hope we'll see development in this area, is that some of the liquid biopsies could help as well. Because if we can actually detect some of the high-risk mutations for the transformation, and liquid biopsy will help us to average signal from multiple sites of lymphoma, including the hot ones or maybe the dimmer ones on the PET scan. This could be something which could be valuable in the future. But as of now, I must say, unfortunately, based on the molecular classification or pathological classification, we do not really have any good stratification system. And that's why we use this composite of experience, tempo of the disease, our impression, clinical impression, PET scan, and all the other clinical information making those decisions. And those are probably one of the most challenging decisions in the clinic we see in a frontline treatment of follicular lymphoma patients, because there are so many variables we take into account.
If I may add a comment, so we have on one side prognostic factors that allows us to predict overall survival in the patient, and basically POD24 is the most important, but for the baseline we also have differences in overall survival across the different risk groups. But at the end, if we compare the treatment that are available, every time we compare CHOP, Benda, or CVP also, we have differences in PFS, but nothing turns into a difference in overall survival. So I think, yes, it is a challenging question, because we are not able to put together risk factor that profiles the risk of death and different options that are on the other side useless to predict and to define difference in outcomes in terms of the most important outcome, that is overall survival.
Yeah, I think I concur with that. However, we should remember that there haven't been really in recent years strict randomization between these different treatment options, except maybe the relevance trial with R-square versus composite of R-CHOP or Benda, and that the choice in gallium was also left by patient characteristic. And if we look at patient characteristics receiving CHOP or Benda and gallium, they differ in terms of age, in terms of tumor bulk, I can't remember about grade, but things like that. I should add to that also that in certain parts of the world and the United States, it's quite possible for the patient to be reimbursed for the R-square regimen based on the relevance data and the NCCN recommendations. So I think that's another consideration for some patient, and that's, I will say, for patient without very significant adverse features such as ISUV or others, even if I can't I can prove a transformation, that will be also one of the regimen I will consider for this patient. But Martin, you have a last comment maybe on this topic on first-line patients.
Very short. My comment was based on detect occult transformation. Secondly, I fully agree that we don't have any molecular prognostic marker really guiding us to change treatment. So this would be then more with a predictive marker, let's say. However, just to be a little bit provocative, I mean, Oliver Weigert published the data on EZH2, and if you believe these data, and that's based on a predefined analysis, then you really, whether you go for CHOP or BR, could depend on the EZH2 mutation status. We do it from time to time, but I fully agree this is no standard of care.
So I think we have here a field that is really still a field of investigation. There is no criteria to define a high-risk patient. It's really based on experience, expert opinions that we feel that some patients have a high risk of failing a regimen like CPP, which is still used in some part of the world, even with rituximab or obinutuzumab combination, that bendamustine of CHOP haven't shown overall a difference in outcome. But if we take into consideration the potential risk of transformation in different categories of patients who may have different characteristics, we may eventually help, this may eventually help guide us. So I will move maybe to the next question, which is the relapse setting. And I think if we can have the next slide. And I think I first maybe like to address some of the risk factors that we define. And I think we have seen a lot of publication in recent years regarding progression of disease within 24 months, POD 24. We have seen also data of progression of disease at 12 months. And we have had now data regarding end of induction PET in several trials. At the same time, many of these data were generated after an immunochemo regimen. And some reports have addressed the issue of patients that were managed by watch and wait or rituximab single agent or even radiation therapy. And I will put aside the question of patients that have went through multiple lines of therapy. So Stefano, when you consider these factors, do we have also a very clear view of the risk factor of this patient? What are your interpretation of all this literature and how it's influenced your management of patients?
Again, I think that we should rely on stable and reproducible risk factors, and we are very few of them until now. Of course, if we can wait until 2 years, we are able to identify patients who are very high risk of dying from the disease, the POD 24. But apart from the POD 24, I think that most reliable and robust data are those related to the quality of response that are defined basically on the use of PET. We know a lot about end of induction PET. There is missing a complete metabolic response at the end of induction is not only prognostic for progression-free survival, but also for overall survival, with a slight increase in the rate of decrease in the survival rates of the patient. This has been validated by several prospective studies. So it's very robust and a very clear signal of a high-risk feature that, in my mind, should be treated very aggressively. For the time being, we have limited option also in terms of reimbursability. I know that there are some countries that are already are available for CAR-T, but this is third line and not second line. So the only option we have in this patient is to try to intensify the treatment. The problem here is to take the patient to high dose therapy, and the issue of high dose therapy, I think, is an important point to discuss, because I realize there are a lot of controversies, and the way the indication for intensification therapy is taken across the world is very different, is not very homogeneous. I perceive this option as an option for most of the European countries, but not for the United States anymore. In terms of, so basically my comment about the therapeutic option is that they are very limited, very weak evidence, very few randomized trial. We only have the recent data about R-square, that however is more related to less, so not a very high risk patient population, because these were patients that were not rituximab refractory, and I see this data apply very well for the late relapse. But for the POD24, I think we are really missing important data, and considering the many options we now have, including CAR-T, including bispecifics in single agent, and in the future, including also CAR-T in combination strategies, we should try to define a role of this novel combination for this high-risk patient population.
Any further insight regarding the interpretation of this recent data? I think we heard, and there are very discordant results according to different publications, that a significant number of patients with early progression of disease after immunochemo may have transformed disease, and these numbers raised from something like 19 or 18 to 20% in gallium to 40% or so in prima, to a series of Vancouver of 70% of the patient or plus with Arbenda. I think it's very difficult to compare those. It's either single center or multiple trials. But I think this is clearly a concern we have when we see a patient. And I think in terms of education for our colleagues, I think it's very important that when they see either, as you said, a positive PET or a patient with early progression, this should be really documented with a new pathology sample. Any insight regarding this diversity of factors?
Sorry, go ahead.
No, my other comment is that we usually keep considering a POD24 patient an high-risk patient, regardless of the number of prior lines of therapy. I believe that this should be taken differently. If a patient is POD24, is truly high risk in second line or third line, but maybe from third line onwards, even if the patient is high risk and classified as POD24, probably the risk is not that high, as high as it was if the relapse was the first one.
I think we'll come to that in a moment with a publication from the Iowa consortium and Leo consortium that I have taken a figure from this data. I think we should also pay attention of the patients that may not be a candidate for immunochemotherapy because they have a much more indolent presentation, and we watch this patient, or some use rituximab single agent or localized disease has been here. Just to remember that the original EFS12 papers actually included this patient and found also that those patients that progress after this form of management within 1 year had also an adverse outcome. And there have been a publication by the Swiss group who is using a lot of single agent rituximab, or by a colleague from radiation therapy, showing also that early progression after what will be considered as an optimal management by many of us will still be associated with a high risk of later disease failure. So maybe to outline what we said, and Stefano to enter into briefly the discussions that you started regarding the different options. We can go to next slide, and I have taken this slide from a paper in Hematologica that we published almost 1 year ago, and you know, I said, what are the options at first progression? We can leave aside the patient with late relapse, low tumor burden, and frail, which are on the bottom of this graph, to the patients that progressed after immunochemotherapy. And you mentioned the controversy or difference in strategies that exist regarding the use of autologous stem cell transplant. I don't know if somebody else would like to mention or to discuss that, because there is clearly a difference. But I should say that even before leaving Europe to the United States, we tended to really use much less autologous stem cell transplant in relapsed follicular lymphoma, unless there was a high suspicion of transformation in the relapse setting. Mike, how are these patients handled in Australia?
Well, it's very heterogeneous, I think. We are transplanting patients with POD24 at my center, but I tell you, the people don't like it. You know, the patients don't like it, and the physicians, particularly in an era where we're seeing such activity from immunotherapies, feel that the whole field should be moving to a different space in the second line. So I think every patient that we transplant with hesitation and a very long conversation. These are patients where we think early about allogeneic transplantation, not necessarily in this line, but thinking carefully about the patient's future. And these are patients also where we're beginning to molecularly profile more aggressively, even if this is not a standard of care and the evidence base is not strong. We would be doing sequencing in these patients and looking for things like mutations in P53 or other risk factors for progression and relapse, and of course evaluating very closely for transformed disease at this time. In the Australian context, we don't have R², so that's not an option, and it's really for lack of options that we autograft patients. But certainly there are some active trials in this space looking at bispecific antibodies, and hopefully there'll be trials that we have access to looking at CAR-Ts, and I'm sure people will enroll to those enthusiastically.
I ask a question to Martin Drailing. Years ago, you were the first to publish the data regarding rituximab maintenance in the relapse setting. Why do you think this strategy still hold in recent years or in the recent time? Is it something you still discuss with your patient, you still consider?
Talking maintenance or autologous?
No, rituximab or obinutuzumab maintenance in the relapse setting.
So it's fair to say I think you can gain the most of it out of it if you apply it in first line, as shown by you, Jill. The point is now we have cut down all the maintenance in first line for the last 2-3 years, and if these patients relapse, I would consider to go for some rituximab maintenance. Having said that, that probably not necessarily are the POD24 patients, but because I think all the data we have is after chemotherapy-based regimens, right? So they should qualify for, again, conventional chemotherapy. That is only for, in my opinion, for the patients who have at least 2 years duration of first remission. We don't do it though after autologous transplant, despite the data out there with the LIM-1 trial. And me personally, I would echo what you said. We don't really push for autologous transplant, but we inform our patients, younger patients with POD24, that we have these data with, at least based on the 2 French series and the German series, improved overall survival. I definitely would push it if I suspect transformation to a lesser extent with a classical follicular lymphoma. Knowing the data of an early relapse with CAR T cells, it's tempting to consider that CAR T cells will take over or immunotherapeutic approaches in general this field, but we don't know yet.
Yes, I think there are still a lot of unknown here, and as you say, it's a moving field. I mean, when we see a patient in third line of therapy, we'll prefer to use CAR T rather than transplant now. So it's hard for me to imagine that we'll do transplant in second line for patients unless some specific features nowadays. But and I think, as you said, there is large difference between the management of this patient across the world, given the lack of randomized data. And I know also randomized study regarding CAR T in second line are being developed by several. So if I can move to the second slide, which is options at later lines of therapy. And I actually, we published this graph 1 year ago, and I already amended this graph. First of all, as obviously we said, clinical trials is always a preferable option for these patients. That hasn't changed. At that time, there was only one CAR T cell that was available, and now we have at least 2 CAR T cells that are available there. And I think the other change, at least in the United States, is the availability of PI3 kinase inhibitors, given the fact that all oral PI3 kinase inhibitors were withdrawn from the market, and the only one that is left available is Copanlisib. Tazemetostat is available in the US, not available in Europe and other places of the world. Mosunetuzumab has been approved already in Europe, while it's not yet. We are waiting eagerly for a decision by FDA regarding the approval of that. And I tended to say that there was no role usually of BTK inhibitors in this setting, given the result of the Dawn study with ibrutinib, and now we have had another study called Rosemont comparing obinutuzumab Zanu versus obinutuzumab alone, which was quite striking in terms of result, although we haven't seen the full publication. So I don't know if Stefano, you already started to address the questions here in third line of therapy. Can you maybe give some insight of those patients that you will consider more for strategy using like CAR T or transplant if it was not used before, versus those patients that we will be managing in a more gentle way, if I may say, or choose a more chronic management for this patient? Can you give some insights regarding the choice you can make?
Yes, thanks. So a first comment to the slide that you're showing is that the decision is also based on what you can use in your country. Of the many options that you show here, for example, we only have R² as an option among the most effective ones. And then, of course, rituximab, radioimmunotherapy used to be an option, but now it's not used anymore. Also, the novel radioimmunotherapy agents, I mean, betalutin agents have been stopped in the development to the best of my knowledge. For example, we do not have tazemetostat in Italy and also in Europe. So, of the many options, again, we only have autologous stem cell transplantation starting from the very intensive treatment, then anti-CD20 plus chemo based on the Gadolin study, basically obinutuzumab and bendamustine. R², it's available since based on the recent approval. And then other options that still include chemo and rituximab. So with these limited options to discuss about what we can really do, it's not very easy to decide. Again, I think that we should, what we do is basically stratify the patient into risk groups. The earlier the relapse, the more aggressive the relapse is, the more intense the treatment should be. I'm not very much in favor of autologous stem cell transplant above second line, so I would not consider this as an option. But generally speaking, but in a patient who has frequent relapse with very short time duration of remission, I would try, but the problem is how to get the patient to transplant in a condition that is optimal for transplant. So how to achieve a CR in these patients. So there are other limited options. So I would try again with our chemo or with our square. So these are the most important tools that I have. Looking at the future, I think that, of course, CAR-T, in my view, based on the results that we saw in the meetings and the experience of some of us in the clinical trials, I think CAR-T are a very good option for the aggressive patients. So very early relapse, so the higher risk population. They allow with one-shot therapy to achieve good responses and to have durable responses. We do not still know how much durable they are, but looking at the shape of the survival curves, maybe some patients can achieve very long remission. And apart from that, in Europe, we are lucky enough now to have bispecifics that I don't see as an alternative to CAR-T, but I think they are still associated with very excellent outcomes in terms of response rate, progression-free survival. The median progression-free survival is close to 20 months. So not the cure of follicular lymphoma, but a good option that is added to other limited options with the limited efficacy. So in one recent patient that I tried and that I treated, with an early relapse, I used bispecific antibody to achieve a response that was deep enough to allow autologous stem cell transplantation. So based on the country we live and the drugs that are available in your country, I think that we are now able to try to find combination and sequencing of treatment, considering that the treatment of a relapsed patient with follicular lymphoma is not always a problem. So one single treatment because the disease then relapses again, but is a combination of available therapies that I hope that will be more and more available in future years.
In third line, it becomes easier for me because chemo is out for me, at least for the vast majority of patients. And that includes autologous. And until recently, for me, standard of care was R-square based on the data when it comes to efficacy. But now the field has changed with the immunotherapeutic approaches. Unfortunately, we don't have tazemetostat. So for me, in the current situation in our institute, we really consider immunotherapy in these patients.
So I like to close with the last slide here, which is this paper published by Carla Cazzulo recently with the data collected by the LEO consortium and looking at the pathway of patients who received first observation and non-systemic treatment for a few of them, then had the first line, which included either rituximab single agent or rituximab plus CHOP plus CVP plus Benda, and then looking at the second line and looking at the third line. And I think while this was obviously patients collected during probably the last 2 decades, and some of them may not have been candidate for new treatment options like that, I think we do see that there is clearly no path preferable, and that this is very individualized decision based on patients and physicians' preference and discussion. And the second major, I think, comment from this paper was that index therapy was, if I recall, line 2, and the 5 years overall survival was pretty satisfactory for this patient. Not fantastic, but still 75% of these patients were alive. Greg, any comments regarding this series of data you were involved in this work?
I think you captured very well. You can see those lines rapidly changing between different agents choose, that this is a lot of based on the physician preference and particular scenario. of the patient at previous exposure to different therapies obviously affects the subsequent choices. You also have to remember that this is already a quite established and mature data set. And we have several additional treatment modalities, including CAR T cells approved since. So this is likely to evolve even more rapidly in years to come, which shows again our difficulty in sometimes rational choosing those therapies based on molecular profiling of follicular lymphoma, which is an unmet need in my opinion, because if we can much better those therapies up front or in the second line to the patients, this would be ideal. But there are a lot of variables, including clinical variables, which we discuss here extensively.
Yes, thank you. Well, I think we should probably conclude here. And again, we are in a very rapidly moving field, although the move is at different speed in different countries. I understand that obviously CAR T for follicular are not necessarily available in all jurisdictions. Similarly, bispecific are not. Tazemetostat, the first EZH2 epigenetic inhibitor, is not in many countries. But this provides options with different ways of managing patients. And I think the lack of clear standard here, which I think is outlined by our discussion, really underline the need to really consider each patient individually and have a discussion regarding patient's preference, goal, whether the patient is ready to go through a more, I will call intensive or treatment at risk, or will like to be managed with few side effects for the treatment with the risk of earlier recurrence. And I think this is a very important process for this patient. I think we are at the top of the time, so maybe we can conclude this discussion.